Hi, I'm Andy Storm, and on behalf of my colleagues and co-authors at Mayo Clinic, we're excited to share our recent manuscript from gastrointestinal endoscopy titled Transpapillary Gallbladder Stent Placement for Long-Term Therapy of Acute Cholecystitis. As you may know, some patients with cholecystitis are poor candidates for surgical cholecystectomy. Ercp with transpapillary, transcystic, double pigtail stent placements to the gallbladder is one option for managing these non-surgical patients. Our study aimed to evaluate a unique subset of such patients with non-operative cholecystitis who are deemed by our surgical colleagues to likely never be candidates for a surgical intervention. At our institution, ERCP for gallbladder stent placement has been performed for quite some time, and over time our practice has been to attempt to place two side-by-side double pigtail stents to the gallbladder when possible, with the theory that wicking between the two stents may result in durable drainage of the gallbladder even well after the stents may become clogged, and therefore provide a long-term therapy for acute cholecystitis. Placement of transpapillary double pigtail stents for acute cholecystitis follows basic ERC principles of cannulation, often biliary sphincterotomy, and then wire-guided cannulation of the cystic duct. This step can be challenging, but is aided by the use of an angled tip guide wire, which through spinning and gentle maneuvering, along with changes in the directionality of the cannula or balloon catheter, will generally successfully reach the cystic duct. Reaching the gallbladder from the cystic duct can also be challenging, especially in the case of acute cholecystitis where a stone, inflammatory stricture, or malignancy may be blocking the way. Using smaller 0.018-inch wires, alternative cannulas, and other ERCP tools may be helpful. After achieving deep gallbladder access with the guide wire, the cystic duct may then be dilated as needed, and then measurements are taken to determine the ideal stent length to bridge the gallbladder and duodenum. In our patients, as side-by-side, two-stent therapy is often the goal, we will sometimes place a second guide wire alongside the first, using either a Sohendra catheter or cytology brush catheter with the cytology brush removed, to place a second wire into the gallbladder alongside the first. After successfully placing the first double pigtail stent, sometimes repeating the cystic duct dilation is felt to be necessary in order to accommodate a second stent. The second stent can then be advanced alongside the first and deployed in a similar manner. Again, in practice, likely allowing for long-term wicking between the stents, and therefore long-term palliation of the symptoms of acute cholecystitis. In our study, 51 patients were referred for destination transpapillary management of their acute cholecystitis. Non-operative therapy was advised due to malignancy in 33 patients, poor functional status in 11, cardiopulmonary disease in 5 patients, and cirrhosis in 2. 49 patients, or 96%, experienced technical success during the procedure. 47 out of 49, or 96%, experienced long-term success from the procedure for therapy of their acute cholecystitis. No deaths occurred, and only mild adverse events, including bleeding and pancreatitis, were encountered related to the procedure. Acute cholecystitis recurred only when the stents were removed and not replaced, or when only one stent was placed, as opposed to side-by-side dual stent therapy. 31 out of 31 patients with 2 stents never experienced recurrence of their acute cholecystitis in our study. We concluded that ERCP for transpapillary gallbladder stent placement was a safe and effective long-term therapy for poor surgical candidates with acute cholecystitis. Risk factors for recurrence were stent removal or single rather than double stent therapy. While not always feasible, double stent therapy may salvage failed single stent therapy or recurrence after elective stent removal. And because of this, double stent therapy is the preferred treatment modality at our center. It is worth mentioning that the increasingly reported role of EUS-guided gallbladder drainage using lumen-opposing metal stents is a consideration in the minimally invasive endoscopic management of cholecystitis and is the topic of a multi-center prospective study including our own institution. Likely, a one-size-fits-all approach won't be the final answer as these varied techniques are compared and contrasted across patient subgroups, and we anticipate that ERCP-directed side-by-side transpapillary double pigtail stents will hold the advantage for some of our patients. Thank you to the editors and reviewers of GIE and for your attention.